Welcome to The Explainer. Today, we're doing a rapid-fire review designed specifically to lock down those high-yield board points for medical students. Let's just kick things right off with a classic vignette. A patient presents with a maculopapular rash and prominent posterior auricular lymphadenopathy. So the question flashing in your mind should immediately be, is this measles or is it rubella?
Keep that exact clinical trap right at the forefront of your mind as we dive in today. Examiners absolutely love to blur the lines between these two presentations, but by the end of this explainer, you're going to have a rock-solid framework to effortlessly tell them apart and secure those really easy points on test day.
Here is our blueprint for this explainer. 1. The bug, rubella basics. 2. Acquired rubella versus measles. 3. Congenital rubella syndrome. 4. CRS risk by timeline. And 5. High-yield exam traps.
Section 1. The bug, rubella basics. All right, let's start right at the source with the virology.
Rubella belongs to the Metenoviridae family, and it's a positive-sense, single-stranded RNA virus. Like a lot of these bugs, it's transmitted person to person via respiratory droplets. But here is the critical takeaway for your exams. It is enveloped. It utilizes enveloped glycoproteins E1 and E2, with E1 being the main neutralizing antigen. Remember that enveloped characteristic because it's going to be our main distinguishing factor in just a second.
Section 2. Acquired rubella versus measles. Let's pivot to acquired infections. Contrasting these directly is exactly where test writers make their money.
Okay, examiners love testing virology differences. If you get a question describing a patient with a rash, and the answer choices are literally just lists of viral properties, cement this in your brain right now. Rubella is an enveloped virus, whereas measles, which is a morbillivirus, is non-enveloped. That single structural difference can often point you straight to the correct answer.
And this brilliantly illustrates the clinical difference in how these viruses actually present over time. Now, both cause a maculopapular rash that starts on the face and spreads downward. However, rubella is often called the 3-day measles because, well, its rash resolves much faster, lasting up to 3 days. A measles rash, on the other hand, hangs around for 5 to 7 days and looks much more confluent.
So, getting back to the crucial point that answers our opening question, prominent posterior auricular and suboccipital lymphadenopathy, that literally screams rubella. While measles will absolutely give you generalized or anterior cervical swollen nodes, it's that very specific posterior auricular swelling that is a massive clinical buzzword for rubella.
Let's summarize this so you have a complete differential diagnosis. Notice the measles column. You've got the prominent prodrome of the 3 Cs, cough, coryza, and conjunctivitis, plus the pathognomonic Koplik spots on the buccal mucosa. Rubella? It lacks all of those. Its prodrome is mild or completely absent in kids. We've also added scarlet fever here as a distractor. If the vignette mentions a sandpaper-like rash starting on the trunk rather than the face, you are dealing with group A strep, not a virus.
Section 3. Congenital rubella syndrome, or CRS. Let's move to the most devastating clinical threat. While acquired rubella is usually a mild disease, in utero infection is a totally different story, and it's a massive source of exam questions.
You must absolutely memorize the classic triad of CRS, which shows up in about 10% of infected infants. Number 1, cataracts. Number 2, sensory neural hearing impairment. And note, examiners will want you to know that's the single most common defect. And number 3, congenital heart disease, specifically a patent ductus arteriosus, or PDA. If you see an infant with cloudy eye lenses, a failed hearing test, and a continuous machine-like heart murmur, you lock in CRS.
Now, what's really interesting is the pathophysiology behind the famous blueberry muffin baby presentation. The purpura and petechia you see on the skin are caused by thrombocytopenia combined with dermal erythropoiesis. Basically, blood is being formed right there in the skin itself. But beware the trap. This look is not pathognomonic for rubella alone. You will see this exact presentation in congenital CMV and toxoplasmosis. You really have to look for the rest of the triad to confirm rubella.
Section 4. CRS risk by timeline. Timing is literally everything when it comes to fetal infection. If a mother is infected during the first 10 weeks of gestation, there is a staggering 90% risk of the infant developing congenital rubella syndrome. 90%. The first trimester is the absolute highest risk period because fetal organs are rapidly developing and highly susceptible to the virus causing direct injury and vascular damage. Looking at the timeline, you can see how the risk drops significantly as the pregnancy progresses. After 16 weeks, major multi-organ defects become quite rare. But watch out for the ultimate exam trap right here. Sensory neural hearing loss is the last defect to disappear. It can still happen as an isolated manifestation with a maternal infection as late as 20 weeks gestation.
Section 5. High-Yield Exam Traps. To finish strong, let's run through a rapid-fire checklist of the sneakiest exam traps regarding presentations and vaccines.
First up, the adult presentation. Acquired rubella is usually pretty mild, but if the clinical vignette describes an adult woman who has a brief rash and then suddenly develops severe joint pain, mark down rubella arthralgia. It's the most common complication in adult females and a really specific board clue.
Next is a massive management trap. If you have a patient exposed to measles, giving immunoglobulin within 72 hours can actually prevent the disease. But unlike measles, post-exposure immunoglobulin for rubella does not reliably prevent infection. It's not routinely recommended, even for pregnant women, unless termination is completely off the table, and even then, it only potentially modifies the symptoms.
Moving on to vaccines. The standard rubella vaccine utilizing the RA27/3 strain is highly effective and gives lifelong immunity. However, because it's a live attenuated strain, it is strictly contraindicated during pregnancy due to the theoretical risk to the fetus. Plus, patients must be counseled to avoid pregnancy for 28 days post-vaccination. Susceptible pregnant women should only be vaccinated postpartum.
But here is the exact trick examiners love to use to test your nerve. What if a pregnant woman is inadvertently vaccinated before she even realizes she's pregnant? The answer is that you never recommend termination. Data from thousands of inadvertently vaccinated pregnant women shows that absolutely 0 cases of CRS have ever been reported from the vaccine strain. Just reassure the patient and monitor.
Before we wrap up this explainer, ponder this final question. Can a newborn look completely healthy at birth only to develop deafness, cataracts, or even type 1 diabetes years later? The answer is unfortunately yes. This is known as congenital rubella infection only, and it makes long-term screening absolutely critical for any suspected prenatal exposure. It's a stark reminder that the absence of symptoms at birth doesn't mean the child is in the clear. Keep these high-yield facts straight, and you are absolutely going to crush these questions on test day.